All right, we'll start now. Good evening, everyone. Welcome to Surge Kuwait's fixed lecture series. My name is Dr. Mohammed Hajia. I'm a surgical resident in the Kuwait Surgical Program. We are welcoming a special guest, Dr. Khalil Ibrahim. Dr. Khalil, he did his general surgery residency program at the University of Miami. He is a fellow in advanced MIS surgery in bariatric and GI foregut surgery. He did his fellowship at the University of California. So I'm glad to welcome Dr. Khalil. If you want to start our lecture series.
Thank you, Mohammed, for your introduction. So today we're going to talk about, peptic ulcer disease, focusing on the perforated peptic ulcer disease, and talk about the medical, surgical management, and hopefully, understand this disease a little bit better. No disclosures for this lecture. So during the objectives, we're going to know more about, peptic ulcer disease. We're going to know more about what causes peptic ulcer disease, what are the complications, how we manage, simple peptic ulcer disease, and what are the surgical options to manage perforated peptic ulcer. And hopefully we can also talk about dumping syndrome and ways to treat that complication in case, it ever happens to you. So, peptic ulcer disease is very variable around the world, yet very common in some parts of the world. Definitely more common in our part than other countries in the Middle East. We see it more common than Western countries, but in general, it's estimated that the lifetime prevalence is about 10%. So 10% of people will have some form of peptic ulcer disease during their lifetime. The incidence is very variable. Now, in one study, it showed that Spain actually had one of the world's highest incidences of peptic ulcer disease at 141 per 100,000 people, and lowest was in the UK. 23, so almost a fifth or a sixth of that incidence in Spain. Another marker where it came to perforated peptic ulcer disease, it showed that South Korea, they actually have one of the highest numbers in the world, and it was about 4 per 100,000. Now let me tell you something. It's very variable due to different etiologies of peptic ulcer disease, but also to the availability of an access to medical care system and the access to data from those countries that allow you to actually see where you are on the map. And I think that's one of the factors why we have such a variability in the reporting of this disease. Now, as everyone knows, peptic ulcer is basically a break or an ulcer in the gastric or duodenal mucosa that causes inflammation and can lead to one of the consequences of having an ulcer there, of the breakdown of the tissue that we're going to talk about. But what really causes the ulcer? One of the most common is H. pylori infection. In fact, about 90% of duodenal ulcers can present with H. pylori infection as a cause, and we're going to talk about how H. pylori affects them. And 60% of gastric ulcers can be related to H. pylori infection, but that's not all. NSAIDs can cause it. Life smoking, alcohol intake, stress by itself can cause peptic ulcer. We see it a lot in hospital or hospitalized patients who have undergone, major surgery, burns, trauma. We see peptic ulcer disease and its complications all the time. And of course, you have other secondary causes such as tumors like gastrinomas that can cause peptic ulcer disease. Now let's talk a little bit about H. pylori because it's very interesting. Prior to 1982, prior to the discovery of H. pylori, this disease was mostly a surgical disease. There are a lot of surgeries that were developed in order to treat peptic ulcer. That all started changing after the discovery in the 80s, and especially in the 90s when we had, the H2 blockers, the modern PPIs that were starting to get invented, and that basically led to a change of this disease from being a surgical to mostly a medical disease. Now, what are H. pylori? Everyone hears about H. pylori, Helicobacter pylori. In the past, it was called Campylobacter-like organism, but now we have basically it's a gram-negative. H. pylori is a gram-negative spiral bacterium, and it has some special abilities to be able to penetrate that mucin gel layer and hide itself in the mucin gel. And then it also has the ability to release urease, making, its environment more alkaline and protecting itself from the ulcer. At the same time, it affects different cells like the D cells that secrete somatostatin in order to increase the gastrin secretion and increase acid secretion in the stomach, causing these ulcers. So the other thing, it can really hide itself from the immune system for a very long time, leading to chronic gastritis. So it's a very smart bacterium, if you wanna say. Now, again, this is really important. When H. pylori infects the stomach, what it causes is depletion of the D cells that naturally secrete somatostatin, decreasing the release of gastrin. And you need gastrin to stimulate the parietal cells to increase acid secretion. So what happens is this unopposed, gastrin hyperstimulation, because of the H. pylori effect, that leads to a lot of HCl being excreted and a higher chance of developing these ulcers. Now, different classifications have been made in order to classify ulcers based on location. Actually, a very interesting and famous one is Johnson. Johnson came up with this classification in order to help physicians differentiate whether the ulcer is due to high acidity or just, not related to acidity at all. They found that mostly type 2 and type 3, when you have, a gastric and duodenal combined ulcers or a prepyloric ulcers, those are related to high acid secretion. If you have a type 1, which is basically one single one at the lesser curvature, it also is associated with hypersecretion. But, when we have an ulcer close to the GE junction, they did not see such a relation with hyperacidity. And, type 5 ulcers, specifically, when you have multiple ulcers all around the stomach lining, possibly due to NSAIDs, it's mostly related to drug-induced and not, hyperacidity. So, that's one of the classifications based on the cause and effect of this disease. Now, patients, gastroenterologists, family physicians, surgeons, they all encounter patients that complain of or that present with peptic ulcer disease. Typically, these patients complain of epigastric pain. Now, depending on the ulcer location, the size, the variability from one person to the other, some patients might tell you, I feel a lot of epigastric pain when I fast and I don't eat, and it might be relieved when I eat. And that's typical of duodenal ulcers. And some patients might say that I have more pain when I eat, and that is more common with gastric ulcers. Typically, because of the pain and because of the discomfort, they might present with decreased appetite, weight loss, and sometimes when the ulcer is pretty deep, it might cause a little bit of bleeding and change the stool color, and patients might present with melanoma. So a detailed history is very important in diagnosing these patients. Now, what can we do to actually diagnose? After history and physical exam, there are different modalities. You see there's a huge list of different tests that are available to detect the H. pylori, either directly or indirectly. We're going to go around one by one and see which ones work best. The most common one is the urea breath test. And what it is basically a radioactive carbon labeled substance that the patient drinks. And that radio-labeled carbon substance breaks down if H. pylori is present, because the H. pylori releases urease. So if that is present, the machine will detect a positive test saying that H. pylori might be present in the patient's breath or in the patient's stomach, really. But remember, it's not very sensitive if the patient just recently got treated or is actually on PPI. So that is a limitation of that test. Another gold standard, what we take is actually histological examination. When we do an endoscopy for the patient, we can take a biopsy send it to histopath, and histopathologists can actually see this bacterium under the microscope. And this is basically considered the gold standard. Other tests, also when we do an endoscopy, we can take a piece of, the duodenum or the gastric mucosa and do something called a CLO test or litmus paper test. CLO meaning Campylobacter-like organism test. And what it is basically once you apply the tissue that has H. pylori to litmus paper, again, the H. pylori, because it releases urease, it's going to convert, to ammonia, making litmus paper turn alkaline, delineating that, the test is positive. And these tests have an accuracy of over 90%. You can also culture, with a biopsy, send it to the lab, but generally it's very expensive and not every center has it. And other modalities like measuring stool antigen is there and measurement of antibodies in the serum. Although when you measure antibody, you don't really know if the patient has active infection, has had the infection and is cured. So, each one has its pros and cons, but I guess the most common would be the urease breath test, the CLO test, which we do with endoscopy, and of course the gold standard is the histopathology. Once you diagnose H. pylori, of course everyone's heard of triple therapy. You use 2 antibiotics, most common being clarithromycin and amoxicillin for 2 weeks, along with high-dose PPI for the first 2 weeks, and then standard 20 milligrams, say omeprazole for the next 2 weeks. And that should be good enough for eradication in over 80% of patients. Now, if the H. pylori is negative in these cases, try to aim at symptomatic treatment and treatment of the underlying cause. If the patient is taking NSAIDs, smoker, alcohol, treat those, stop those. Start them on PPI. You can also start them on coating agents like sucralfate. You can also, if the history doesn't really match, think about other causes of gastritis, not just H. pylori and these causes. Patients might present with, inflammatory bowel disease confined to the stomach, causing ulceration and, pangastritis. So you might want to take biopsies and send them to the lab. Other different forms of diseases might also be present that can also mimic, peptic ulcer disease. Of course, if you're dealing with a gastric ulcer, make sure you biopsy the ulcer. You need at least 8 biopsies in order to rule out malignancy, especially in gastric ulcers because of the higher incidence of gastric cancer in these lesions. All right, before we talk about the surgical treatment now, let's have an overview about how gastric acid is produced. As you can see, the parietal cells, mostly located in the fundus and the body, produce HCl through HK ATPase. Now, these parietal cells are controlled by different modalities, namely the vagus. The vagus controls about 60% of the acid production by the parietal cells in the stomach. And another stimulator of the HK ATPase to produce HCl is actually the gastrin. Gastrin is produced by G cells in the antrum. And this is where H. pylori acts, It causes overstimulation of gastrin that helps, stimulate the HK ATPase to make more acid. Now, histamine could also have an effect, and it can stimulate, acid secretion. And this is where, the H2 blocker, cimetidine, like Zantac, acts to block. Now, like there are stimulants to acid production, there are also inhibitors such as prostaglandins and somatostatin that help regulate how much stimulation is there to this cell and how much acid is produced. Of course, I want you to focus here, omeprazole. Omeprazole and PPIs were really developed in the 90s, and then right now you can find them in every pharmacy on every shelf. And the market is so big because of the effectiveness of this. Remember when I said the vagus controls about 60%? Now if you hit the patient with omeprazole, then you're getting 95 to 100% blockage of acid secretion. So it's pretty amazing how right now we can control and block the acid production just by this medication. Okay, so let's, in order to talk about the surgical treatment of peptic ulcer disease, we need to go a little bit back. Initially, back in the late 1800s and prior to 1980, what we call ulcer surgery was very common. Patients presented with peptic ulcer disease. They did not really have good ways to treat them, maybe a few medications and stuff, but some patients had these refractory ulcers and they were going into complications of pain, bleeding, perforation, gastric outlet obstruction from scarring, all of that stuff. So, different surgeons came up with different techniques in order to treat this disease. So let's talk a little bit about, the first one, Vagatomy and Pyloroplasty. There are different types of vagatomy, aiming to decrease, innervation of the parietal cells, thus, blocking the stimulation and the effect of vagus on the parietal cells and its acid production. So what they came up with initially is, okay, how about if we go to the vagus, okay, and do something called a truncal vagatomy. We can dissect the hiatus, identify the anterior, and identify the posterior vagal trunks, and we can basically transect it. That will give us about 60% blockage of the acid, and hopefully, the ulcer that is available or that is present, in the stomach can heal because we just created a medium with less acidity. That's one option. Another option is, hey, how about if we go a little bit further and just cut the anterior vagus? Okay, we call this a selective vagatomy. We only select the anterior vagus and we cut it. That also will give me the similar, 60% blockage, but it's going to spare a lot of the branches of the vagi. Now, remember, if you're doing a selective or you're doing a truncal vagatomy, you basically are disrupting the nerves called, the nerves of Latarjet that supply the pylorus to allow it to relax. So when you're really affecting these nerves, you're going to cause the pylorus to shut down. It's not going to open when food comes in. So if you're doing a truncal vagatomy or a selective vagatomy, you need to do something called the Heineke-Michelitz pyloroplasty. You basically open the pylorus, okay, longitudinally, and close it transversely in order to reshape the pylorus to keep it in the open position. And that should take care of the side effect of the vagotomy. Okay, so when you do these, what was the problem with vagotomy also? Vagotomies, one, they do block 60%, but you have the side effects of truncal and selective vagotomy that you also cut all the nerve supply to the intestines, to the pancreas. Some patients were getting dumping syndrome, undesirable side effects, diarrhea. So other surgeons said, hey, instead of cutting the trunk, how about if we do something called a highly selective vagotomy, or like it's also called a parietal cell vagotomy. You go right at the cross foot, okay, and you just cut all the terminal branches that supply the parietal cells that are basically mostly located in the fundus and the body. And that seemed to work without the need to do a pyloroplasty because you're really sparing the nerves of Latarjet. Okay, so that was one surgery that was developed in order to take care of these ulcers that weren't healing, that were causing a lot of trouble. Okay, so people were not happy with just 60% blockage of the acid secretion. They wanted more. So what did we talk about? We talked about the parietal cells being stimulated 60% by the vagus, but also a significant portion by other modalities, one of them being the G cells, the gastric. So what Dr. Billroth, who is one of the founders of modern abdominal surgery, okay, back in, early 1900s, he basically, okay, came up with another surgery saying that, okay, let's do the truncal vagotomy, cut down to 60%, and then let's do an antrectomy, especially if there's an ulcer right here. We can get rid of the ulcer, we can get rid of the antrum and the gastrin secreting, cells, and we basically can reconstruct it. Now, when you add an antrectomy to the vagotomy, you achieve about 80% blockage of acid. And that was the appearance. So 1, you do a vagotomy. 2, you do an antrectomy in order to get rid of the G cells, and you remove the ulcer as well. Now, with reconstruction, we can bring the duodenum and anastomose it to the gastric pouch called the Billroth 1. Or if it doesn't reach, or because of the scarring, because of all the adhesions, we can bring a loop of jejunum and we can anastomose it and call it a Billroth 2. Alternatively, we can bring up a limb and we can call this a Y reconstruction. Okay, but same concept. Antrectomy plus vagotomy gave you about 80% blockage of the ulcer. Get rid of the ulcer, patient basically lives a better life. But again, it also was associated with a lot of other side effects such as dumping syndrome. These surgeries were not without significant morbidity. So they had their fair share of complications also. Okay, then came along, the other surgeons that said, okay, how about if we have an ulcer, but it's not in the antrum, it's in the body, it's in the G or close to the G junction. How can we do the antrectomy vagotomy business here? One of the procedures was actually called a Pouchet procedure, which basically aims to remove the antrum, which has the G cells, okay, but also extend your excision to include the ulcer right at the lesser curvature. And another one was the Sens procedure, which basically did what is known, a subtotal gastrectomy, really, to also include the ulcer within your resection, and then you reconstruct it with a Y. So, we covered, H. pylori as a cause, different causes of peptic ulcer disease, the medical treatment, the history of ulcer surgery, as we call it. Now, let's focus on the perforated peptic ulcer disease and how we treat it. And we see how these different surgeries play their role. Okay, so one of the complications of a peptic ulcer disease is a perforation. You can have a perforation in the stomach, or you can have a perforation of the duodenum. These perforations might be very small, a few millimeters, and they might be giant, a few centimeters. When we refer to giant ulcers, we usually refer to an ulcer more than 2.5 or 3 centimeters, which makes their repair a little bit more challenging. Okay, so perforated peptic ulcer disease. Your patient usually comes into your emergency room complaining of abdominal pain, chronic abdominal pain, probably loss of appetite, but his pain just all of a sudden got so bad, it's worsening in intensity. Maybe it started in the epigastric region and now it's all over. He usually have other signs of systemic sepsis, such as fever, nausea, vomiting. All of these are factors that you need to, dig in and find out from the patient. Also, it's worthwhile to see if the patient is a smoker, has been on any NSAIDs, has been taking alcohol. During your examination, you might find out that the patient has fever, tachycardia, and hypotension. Why? Because he has enteric content in his peritoneal cavity with bacteria in places that it shouldn't be. And now he's suffering from the systemic consequences of this sepsis. When you do an examination, the patient might be dehydrated. So you should think about, resuscitating the patient. Their abdomen will range from, just mild epigastric tenderness to full-blown guarding and board-like rigidity when you examine it, which is usually a later sign. That means this ulcer has been perforated and has been cooking for a while. So what do? First thing is send labs, right? You check a WBC, you check other inflammatory markers if they're available in your center, such as ESR, CRP. You check the renal function test, make sure your patient doesn't have renal failure because of dehydration. Don't forget, these patients might have been perforated for a couple of days, okay, before they present to you. They haven't been able to eat, haven't been able to drink, they might be dehydrated. So you need to dig into those. Next beneficial exam is to do a chest x-ray. See, in this chest x-ray, we see a rim of air in a place where it shouldn't be. Okay, so it's right here under the right diaphragm. And also if you can, focus here, you see the stomach with its lining, but also you see some air just above the stomach. That's because he has a perforated viscus, and now the air basically just traps underneath the diaphragm. So chest x-ray is very useful, an upright chest x-ray, of course. Even better, go ahead with a CT scan if it's available. Okay, do a CT, okay, with contrast. And in this CT, we see that there is free air, okay, above the liver, and there's moderate to large amounts of fluid, okay, from the perforation. So this is one of the signs you might spot in a CT scan. How do you manage these problems? First thing, resuscitate. Don't take the patient directly to the OR. Yes, you want to take them, but initially give them fluids, resuscitate them, okay? You'll make your life as well as the anesthesiast's life much better, okay? Give them IV fluids, start them on antibiotics, give them PPIs, put an NG tube down, put a Foley catheter, resuscitate them, and then plan for operative management. These patients need to go to the OR as soon as possible because you need to control the source. You need to control the sepsis. Before we talk about the details, now I usually get this a lot, okay, during my teaching rounds and everything. Depending on your center, you're going to basically ask yourself, when a patient comes in with a perforated peptic ulcer disease, should I give them a bolus and then continue with a PPI infusion for 72 hours typically, or should I give them, a bolus, high dose, and then continue with intermittent dosing, BID, high dose PPI? So one of the tests, okay, we use, or one of the studies is this amazing systematic review out of Yale that compared doing intermittent dosing of PPI, okay, with, continuous PPI therapy after a bolus, but this time for bleeding, okay? And what it showed is both therapies are equally effective, okay, and had equal chance of 7-day bleeding risk when we compare them. So there isn't really much difference if you want to give the patient high dose PPI BID versus giving him a continuous drip. The whole idea behind giving PPI is to raise the pH from the normal 4 to 4.5 to about above 6. Okay, and what we saw was both of these regimens work the same way and have the same effect. Now, what do you do if you take the patient to the OR and you have a duodenal ulcer, a perforated duodenal ulcer? What are the managements? What are you going to do? First of all, depending on the comfort of the surgeon, you might want to go with a laparotomy or a laparoscopic approach. Whichever it is, you want to explore the patient. First, you identify the site of perforation. Most of these duodenal perforations happen at the anterior portion of the duodenum in the first part. Next thing you want to do is you want to repair the perforation, and we'll talk about different methods that are available to repair. The second thing is you want to control the sepsis by washing out the abdomen and irrigating everything that's filled in the abdomen to the outside. Okay, so do thorough irrigation. And the last thing is you want to put some drains and you want to close the abdomen. Now, everyone's heard about the Graham patch. You have a very small, first portion of duodenum, simple, clean ulcer. One way to treat this perforation is just to close it. What is the problem? Usually you have inflamed tissue. Whenever you take your bite, it's just going to rip. It's not really going to be that secure. And there's a high chance of the sutures, ripping through the tissue and the perforation recurring days after you fixed it. So what happened was, or how the Graham patch was developed was Dr. Graham, okay, an Australian surgeon, came up with this surgery in the 1930s. And he published a good series of data, okay, showing the effectiveness of this surgery. And ever since, until this day, it has been working beautifully. So what you do is basically you get some, good portion or nice, healthy tongue of omentum, what we call, and then you basically want to suture your ulcer, okay? And you want to basically take the omentum. The way I do it is I take one bite through the edge, and then I take another bite through the omentum, and then another bite through the opposite side of that edge, okay? And then tie it down, and you can do a couple of them if your hole is bigger than expected, 2 or 3. Now, please note that there are multiple variations of the way you buttress the omentum to the perforation. The way I do it is one, okay? I talk to you about. Some people lay their sutures, then put the omentum right there, and then tie their suture above it. Some people, what they do is they basically tie a knot, okay, and then they put this omentum over it and tie another knot over it. So the whole point is you want to put the omentum inside the hole and secure it with some sutures, okay? I want to make sure that stays well and secured over there. All right, so how about if you have a little larger ulcer? That works very well, if you have a 1 centimeter or so, but how about if you had a 2 centimeter ulcer, duodenal ulcer? What do you do here? Another option is, okay, same omental patch, and it works for bigger ulcers, but if you can't, you can also bring, a tongue of omentum, and you can, suture the edges, okay, to the edges of the ulcer itself. Let me show you how. So you bring the omentum down here, and then you take a bite through the duodenal wall, and then through the omentum, and you tie it. And you do the same thing with this side, okay? Bowel, omentum, tie. Bowel, omentum, tie. So it becomes like a patch over it. Same thing, omental patch, but instead of closing over, you just suture the edges. That might work, okay? What about if it doesn't? You don't have really healthy omentum, everything is so inflamed, you're not happy with your suture, it's a little bit of a large ulcer. What can you do? Another option is called a serosal patch. You bring a bowel loop up and you suture the edges of the bowel loop to the nice healthy edges of the duodenum. So essentially you're blocking this hole by using the wall of the bowel. So that's another option, and it works for larger ulcers too. It's called a serosal patch. Beauty is you have a vascularized flap, okay, and you're using it to close off this wall, okay? So you suture here, and so on circumferentially. So you're going to block this with the bowel loop. So that's another one. Say nothing works. What are you going to do? What other options do you have? In extreme cases, you might want to think about bailing out, okay, but with putting, a duodenostomy tube. This idea is used, okay, mostly in trauma, but you can also use it in perforated duodenal ulcers. The whole point is basically you have a hole and you can't close it. You tried everything that I talked about and it doesn't work. So what do? Here you want to put a drain inside a Malkowitz drain, and you want to suture the edges to suture it tight shut, and you want to exteriorize all the enteric contents to the outside. You also want to put a drain just next to the perforation on the outside, the peritoneal cavity. What this aims is basically after 4, 6, 8 weeks, of course with good nutrition, that this is definitely going to close. If you have no obstruction distally and you have good nutrition, this ultimately will close and fistulize to the outside. And then after 6 weeks, you can slowly remove the tube, and that fistula of the duodenum to the skin will ultimately close. Of course, with this repair, you always have to think about a feeding axis, because feeding is going to be critical in healing these patients. What else? You might have heard about, duodenal exclusion. Again, another extreme surgery that is used mostly in trauma. We use this in trauma cases, but also it's a useful tool to use in very complex duodenal ulcers. And it's also good to know about it, okay? So here's the idea. You have a perforation. You close the duodenal perforation, and it's very complex. You're not really comfortable with all the food and all the fluid that's gonna come, through the duodenum. It might leak, it might open. So what you want to do is you want to exclude this area from any gastric juices coming down. So what you do is after you repair it, you open and you do a gastrotomy. You identify the pylorus, you suture the pylorus closed, okay? And you do a gastrojejunectomy. And what that does is you just shut down the pylorus, so you're not going to have food coming down into the duodenum. And in fact, you just created a new way for the food to go down so the patient can eat and they can digest the food and the food can go down through the gastrojejunectomy. Now, some people ask me what type of suture you can use. Usually you use a permanent and then you go in endoscopically and cut it, okay, after like 6 weeks or so. But again, there are different variabilities of the techniques. All right, so, this is how we repair perforated duodenal ulcers and manage them in general. And, next we're going to talk about perforated gastric ulcer. Okay. When you talk about, perforated gastric ulcer, it is important to consider whether this ulcer is really just a regular peptic ulcer that has perforated, or is it really a gastric cancer that perforated? So that's the first thing that comes in mind. And the way to know is from different things. First thing, dig into the history. Has this patient been on, has this patient been treated for peptic ulcer disease? If yes, then that might be a complicated peptic ulcer not responding to treatment. Is he on PPI therapy right now? Again, if he perforates while being on PPI, it will change your, thought process and which surgery you're going to give him, which I'm going to explain in a second. Any history that might suggest that might be a cancer? Does he have a family history of cancer? Was he scoped, and does he have any biopsies in the past for showing that he has gastric cancer? Does he have any weight loss, malnourished, any NSAID uses? So these pieces of information are very, very important when you consider patients with perforated peptic ulcer disease. How do you manage gastric ulcers? Same thing. You're going to go in, you're not going to know. Is it gastric? Is it, duodenal ulcer? So same thing. Resuscitate. Antibiotics, IV fluids, put a Foley, put an NG tube, type and cross, take them to the OR. What you're going to do is you're going to assess the patient for stability first. The first question I want to see is he stable or is he unstable? Can I spend 2-3 hours repairing this guy, or do I need to do a 30-minute job and bail out and maybe come back later? Those things need to be in your head right now, okay? First thing you do when you see a gastric ulcer, I want to know, am I dealing with a cancer, okay? Or am I dealing with peptic ulcer disease? Biopsy it, send it to frozen section, and then find out. Frozen section is available in most hospitals. If it's available, take advantage of it. Get the ulcer biopsy, and if it is benign, then you could consider two things: either just closing the defect, okay, putting drains, wash out, same as the duodenal ulcer, or do you want to consider giving the patient an ulcer surgery that we just talked about? Let's do some examples so it solidifies a little bit better, and you can understand a little bit better how this works. So this is actually a real life case that we did in our hospital that I did about 2 months ago. So this patient presents after placing an intragastric balloon, and for 6 weeks, nausea, vomiting, abdominal pain daily, used every medication available, and she also admits to smoking. 23, smoker, and she was taking excessive NSAIDs because of the pain that was caused by the gastric balloon. So right from the get-go, I know that 23-year-old on NSAIDs balloon, this is a peptic ulcer disease. This is not really a malignancy. So I'm comfortable, giving her the following. First thing is I'm comfortable, giving her the following surgery. Just identify the perforation as we can see it here. This is the laparoscopic view, by the way. This is the endoscopic view. This was a combined case. And then what we did was we closed it in 2 layers, and this is the closure. Now, After closure, we tested it, okay, and there was no leak, so we're happy with it. Now, the question that I'm going to ask myself, do I need to do a vagotomy here or one of the ulcer surgeries? You know, truncal vagotomy, selective vagotomy, highly selective vagotomy? Not really. I have a cause. She has NSAIDs. She was taking NSAIDs. She has, you know, balloon. So I really don't need to give her one of those radical surgeries. Plus, we have PPIs. PPIs, okay, block 100%. And that's why you don't see a lot of vagotomies happening these days. So with this simple case, you have two options. You can close her with 2 layers, put drains in the abdomen, wash her out and get out. Or what you can do is, if you don't want a suture, the other alternative is to put an endo-GIA stapler and just staple across it, okay? Those are the 2 options here. Another scenario, okay? Patient comes in with a perforated ulcer, but this time you really cannot, you know, you try to close it, you take a biopsy, it's peptic ulcer disease, first time, they haven't been on PPI, they haven't been, you know, they don't have high risk factors. You take a biopsy, as we said, it's benign, but the problem is you can't close it primarily. It just wouldn't come together. So you need some help. Mr. Omental comes to the help, okay? You could put in a mental patch and you could close over it. A mental patch works very well even for benign ulcers of the stomach. So I can close it with a mental ulcer, okay, or a mental patch. It closes ulcer. And then, do we need to do a vagotomy or anything? Not really, because we have the PPIs. Nowadays, we have PPIs that we can use. Another option, the ulcer is a little bit big. You can't close it because it wouldn't come together, but it's a little bit mobile and you think you can wedge resect it. So another thing is to use a endo-GIA like we talked previously, and you can cut it out and wedge it out. Now, where is this also beneficial? This is beneficial when you have a nice, you know, ulcer that looks ugly, that you send a biopsy and you're not really convinced that it's benign, you still think it's malignant. What you can do is you can excise the whole ulcer using an endo-GIA stapler and then send that ulcer to a permanent section. And then, you know, in a week or so, they're going to tell you if it's cancerous or if it's not cancerous. And depending on what it shows, you basically can decide what further management the patient needs. In order to do this, you need the edges to be mobile. It's very important. It's not always mobile. Okay, so now you're going to ask me, you know, where does ulcer surgery come in? And how does it work? Ulcer surgery is still used, although very rare. There are some people who benefit from ulcer surgery, and that's why it's important. That's why we still teach it to our residents. So ulcer surgery is a definitive ulcer surgery. It is, you know, we resect the ulcer, we do the vagotomy, we do, you know, the reconstruction. Say a patient comes in and this patient has been treated for H. pylori in the past, continues to have an ulcer, is on PPI, and still comes with a perforated gastric ulcer. Now with this patient, you want to give him a definitive surgery. You know that the PPI by itself did not work. So you need to give him something more radical. So what you do here is you want to excise the whole, you know, antrum that includes the gastric with the ulcer. Hopefully if the, you know, ulcer is located in the antrum right here where I'm showing. You want to do, you know, a truncal vagotomy to cut the 60% that we talked about, acid production, and then you want to reconstruct with either a Billroth 1 or Billroth 2. Where does this surgery play a role? In the scenario I just told you about. And if you have a large ulcer that is fixed, that is not mobile, that you really can't wedge, you can't close primarily, or you can't do an omental patch, then you have to resect it. There is no other way. Okay, so research-wise, or does the data support, you know, omental patching versus gastric resection? Actually, you know, there's this paper that was published in American Journal of Surgery comparing whether omental patch was as good as gastric resection for the treatment of patients with perforated gastric ulcers. And what it shows that the patients actually had similar morbidity, similar mortality, and there wasn't any major difference. And that's why we do, a metal patching and prior repair and all the options that I told you. Now, there are some special considerations when you're dealing with perforated gastric ulcers. You take a patient to the OR, patient's hemodynamically unstable. You have an immobile ulcer and you want to do an antrectomy. You can't really close it, you can't omental patch it, you want to do a gastric resection, but he's too unstable. The abdomen is, dirty. You don't have the luxury of time. So what can you do here? It's okay to, to just resect it, leave him in discontinuity, keep an open abdomen, take him to the ICU, resuscitate him for 24, 48 hours, and then come back to the OR. If you don't have the expertise, you might bring someone who does, okay, in order to assist you. These surgeries are not very straightforward. So it is an option. Just keep it in the back of your head. It is okay to do damage control surgery in these settings. Another special consideration, some patients might present, okay, in a stable fashion. They're, a little bit of an epigastric pain. You do a CT scan, you see that the contrast is not extravasating, but there are, or not extravasating, or there are signs of perforation, duodenal ulcer perforation, but the patient is stable. Maybe he has a little bit of a collection, he's stable, he's high risk. You're not, a big fan of taking the patient to the OR yet. Is there a role of conservative management? Or should I say non-operative management? Yes, very, very limited, okay? This should only be done specific cases, and it basically mostly used for really high-risk patients. Patients come in, they're on, aspirin, Plavix, cardiac disease, pacemaker, and they're stable with a very small perforation without systemic sepsis. You can try to give them bowel rest, IV antibiotics, monitor them very closely, put them on PPI, and might want to consider percutaneous drainage. And then after, 3, 4, 5 days, you want to consider a gastrographic study to see if the perforation is sealed or not. So that is also something that you might want to consider. Excuse me. So follow-up after repair of the peptic ulcer disease. You repaired your ulcer, let's say gastric or duodenal ulcer. So it depends. It's very variable from one center to the other, whether you do a follow-up study, like a gastrographic upper GI study or not. But in general, these patients will have possibly an NG tube for a couple of days. They'll have abdominal drains, until they're tolerating diet. And a lot of centers might consider, a gastrographic upper GI study in order to document that there is no leak post-repair. Probably done post-op day number 3 prior to starting the patient on a diet. The patient is initially started on clear liquids and then advanced to regular diet, IV fluid is tapered off, ambulate, and then after discharge, you want to consider, triple therapy, you want to consider PPI, and you want to avoid precipitating factors like, smoking, use of NSAIDs. And then, after 6 weeks of treatment, you got to stop the PPIs for at least 2 weeks and then do a urea breath test to see if you eradicate the H. pylori. Okay. Now, our last part, we'll talk about dumping syndrome. So, what is dumping syndrome and why does it happen? Dumping syndrome has about 10 to 50% incidence after, any gastroenterostomy or vagotomy with pyloroplasty. It basically is a constellation of different signs and symptoms involving, patients feel tachycardic, dizzy, they have excessive sweating, altered bowel habits like diarrhea and nausea. And why this happens is basically any procedure that interferes with the normal activity of the pylorus will predispose, can predispose to dumping syndrome. And what happens is, food reaches the distal GI system very fast and predisposes to these side effects. So there are two things when considering dumping syndrome. You gotta basically find out, is it early or is it late? You have this rapid emptying, but are you getting the symptoms early or are you getting them late? And each one has a different pathophysiology. Early is when patients eat, and then after 15, 30, 45 minutes, they develop these symptoms of flushing, diarrhea, abdominal pain, nausea, bloating. And this is thought to occur because of this rapid transit of the food bolus from the stomach down to the jejunum and ileum, causing all this influx of bowel and then bowel distension, and all this effect happens. That is early. Late, however, is mostly due to the hyperinsulinism response with the reactive hypoglycemia. This food that is usually high in sugar is dumped, okay, and into the distal GI tract, and after an hour or two, the patient complains of the same symptoms. But this time it's because this food is rich in carbohydrates, and it caused a spike up of the insulin, and with reactive hypoglycemia going down. It also is thought to be, or GLP-1 is thought to have also an activity of mediating this effect and causing the hypoglycemia. So, workup is mostly through history and physical exam. You can diagnose patients just by listening to them, examining them, and finding out and checking for the symptoms that I told you about right now. Now, the diagnosis also, or through the diagnosis, you want to do a couple of tests in order to document it. So one of the tests is the oral glucose challenge test, where you tell them to drink 50 grams of glucose, and you see them develop symptoms. That is one. Two, you also want to add in an endoscopy to delineate the anatomy. Is this patient having dumping after a Roux-Y bypass, a one anastomosis gastric bypass like a Billroth 2, pyloroplasty and vagatomy? What exactly is causing this? Now, also you want to do a gastric emptying study in order to document that the food is actually undergoing rapid transit and rapid, evacuation from the stomach and causing these symptoms. So those are the three tests that I recommend whenever you encounter a patient with dumping syndrome. How do you treat it? We said the first thing, food rich in carbohydrates are usually one of the causes, or the most common cause of dumping syndrome. So you ask the patient to eat small, frequent meals instead of eating large meals. You reduce the simple carbohydrates and you give them more complex carbohydrates that take a little bit more time to break down and be absorbed. The other thing is, especially for patients who suffer from late dumping syndrome, which happens because of the hyperinsulinism, you might want to prescribe a carbos. So if small meals fail and all of that, you want to give them a carbos. And carbos is basically an alpha glucosidase inhibitor that inhibits the conversion of polysaccharides to simple sucrose and might help alleviate their symptoms through decreasing the absorption of this sucrose. That's one of the drugs that we use to treat dumping syndrome. The other thing you might want to give the patient somatostatin. What somatostatin does is it shuts down a lot of the hormones. It decreases the gastric emptying. It resets the migrating motor complex. We think dumping syndrome happens because this migrating motor complex pushes food, through the intestine, and somatostatin might help decrease these electrical activities in the intestines and possibly alleviates the symptoms. Now, as you know, somatostatin occurs in two forms, it's prescribed in two forms. One is the daily, given 3 times daily, and there's the depot somatostatin or depot octreotide, which is prescribed as 1 shot once a month. Let's say you give the patient everything on the table, from medications to dietary and lifestyle modification, nothing works. So what can you do? There are surgical treatments to this, and let's go over them very quickly. First thing is, you have a patient with a Roux-Y gastric bypass, and he has a large stoma. The gastrojejunostomy is very large, so food can travel down the GI tract pretty fast from the stomach to the distal bowel. One way to treat this problem is to do something called a stoma revision. We actually go endoscopically, and by using endoscopic suturing appliances, we can narrow down these stomas and make them smaller. So the food now stays longer in the stomach and takes its time. Okay, just doesn't just go all at once distally. So stoma revision is one option. It is very useful for patients with Roux-en-Y gastric bypass with dumping syndrome. Another useful treatment for dumping syndrome is conversion from Billroth 2 to Billroth 1. Remember, we said Billroth 2 is a gastrojejunostomy. Billroth 1 is a duodenogastrostomy, a gastroduodenostomy. So here, food comes down and goes to the distal bowel way faster than if it were to go through the duodenum. So the whole idea is if I reconnect the duodenum, I will give food a little bit longer time to pass through the normal tract and be absorbed and not have this effect of the dumping syndrome that we encounter. Okay, so one of the other options is if they have a Billroth 2, you might want to consider Billroth 1. And this is very interesting. Rarely done, but very interesting. Okay, say a patient had a Roux-en-Y bypass and they still have dumping syndrome. What can you do? You can do something called an anti-peristaltic jejunal segment interposition. Usually, you go to the roux limb, and in the normal anatomy, all the contractions are going one direction down from proximal to distal. What you do is you cut out this 10-centimeter segment, you flip it around, and now you reconnect it. Now what happens is this segment is working against the flow of the food. So the stomach contracts down, the distal bowel contracts down, but this segment contracts back up just by flipping this 180. Now, does this cause obstruction? Not really. It's only a 10-centimeter segment, but this might work in some patients. Okay. Last but not least, if the patient had a Billroth 1 or Billroth 2 and they still have dumping syndrome, you might want to consider converting them to a Roux-en-Y bypass. And in fact, there are a lot of studies that show that Roux-en-Y bypass actually works very well for dumping syndrome. And the mechanism is not fully understood, but it's thought to slow down the chyme transit through the roux limb and maybe interrupting those motor complexes, electrical motor complexes that stimulate the bowel. Okay. All right. So Dr. Ali, let's go through the MCQs. Dr. Mohammed.
Yep. We'll go for the first question. Dr. Khalid, would you like to?
Sure.
Yeah.
Sure. So, got a couple of questions here. The first one is a 55-year-old female, diabetic, hypertensive, coronary disease, pacemaker, had a perforated peptic ulcer disease about 2 years ago. And she underwent a antrectomy, truncal vagatomy, and a Roux-en-Y reconstruction. She has been treated for dumping syndrome, which occurs 2 hours after meals. She got a carbose, diet modification, somatostatin, without significant relief. Now, what is the most appropriate management for this patient, do you think? Is it A, prescribing loperamide next, B, conversion to Billroth 1, C, endoscopic stoma application, or D, jejunal interposition?
The answers are going in live, as you can see. Just a few more seconds. Okay. What do you think, Dr. Khalil?
Okay. The right answer is endoscopic stoma plication. Now, let me go through very quickly and tell you why that. First of all, okay, look at this patient, very high risk, okay, diabetic, hypertensive, pacemaker, you know. To give her loperamide is, you know, an antidiarrheal agent. It does not really do much for, you know, dumping syndrome. Conversion to Billroth 1 is not the most ideal thing for this patient because you basically, you have a patient who already had a Roux-Y, who had previous surgery, okay? So you don't want to do that. Endoscopic stoma plication might be the most appropriate one because you want to, it's an endoscopic. You don't need to go into deep sedation or general anesthesia as much, okay? And it would give her the best option. Jejunal interposition might be a valid thing if endoscopic stoma plication fails. All right, so always look at the patient's history, see which one's most appropriate for that patient. Okay?
We'll move on to the next question.
Okay. Which of the following has the most effect on reducing gastric acid secretion? Truncal vagotomy, highly selective vagotomy, antrectomy, proton pump inhibitors.
Give the audience 30 seconds to answer. If anyone has any question, please ask them out in the Q&A panel. I'll gladly read out your questions to Dr. Khalil. Okay. I have a mix of answers, Dr. Khalil.
Okay. All right. So the right answer is proton pump inhibitors actually has the most reducing gastric acid. And that's why right now, again, I reinstate the, you know, the point that one of the reasons why we stopped doing truncal vagotomies, antrectomies, and highly selective vagotomies is because of the development of the proton pump inhibitors that give me 95 to 100% blockage of parietal cells. So what they do is basically what we call chemical vagotomy, okay, with a pill rather than surgery. So truncal vagotomy and highly selective maybe drop 60% of acid. Antrectomy by itself is 20%. With, you know, vagus, it gives you 80, but proton pump gives you 95 to 100. Yeah.
Perfect. We have one question from the audience, Dr. Khalil.
Yeah.
We have one anonymous attendee who is asking, should the amental patch be kept upon the duodenum or within the duodenum for patching?
Okay.
So yeah.
I prefer that it's within the duodenum and then wrap over it, not just on top, because what some surgeons do, they close the hole and then put it on top, and then, you know, the whole suture just rips out of your repair and the duodenum just flies out. So when you put it inside the hole and suture it, it gives you a better chance of it staying inside and fibrosing and ultimately, you know, the bowel wall healing on top.
Any other questions, guys? I think that's it, Dr. Khalil.
All right.
It's been a pleasure having you. It's a very informative lecture, as always.
Thank you so much. Pleasure is all mine. Thank you so much, guys, for this amazing, you know, preparation.
Do you have any questions for us?
Keep on doing what you're doing. Your guys are amazing.
Perfect. Thank you so much.
Thank you. Thanks.
That will be all. Thank you, Dr. Khalil. Now, if anyone wants to join our other series, we have the ABCs of Research by Dr. Sara Al-Yuha. If anyone who hasn't registered, they are welcome to register. It gives us an informative lecture series on how to write a research paper, how to publish a research paper. Just basic steps, especially for junior doctors. It's really informative. Our next session will be next Sunday, inshallah. It will be with Dr. Sinziana Dumitra. It's going to be about GIST. So please, you guys can all use the QR codes to register. And if you haven't followed us on Instagram, Twitter, you can also do that by copying the QR code on the screen. So we're gladly going to share the screen for a few minutes for anyone who wants to join us. Thank you so much, and we'll hope to see you next week. Take care.